Good evening and a very warm welcome to the ninth episode of very popular webinar series, Master Techniques. I am Maneesh Bhatia, consultant foot and ankle orthopedic surgeon in Leicester. On behalf of the Education Committee of BOFAS, I would like to welcome you all. Tonight's webinar is on Morton's Neuroma, the present and the future, and it's something which is very close to my heart as well as I love this topic. Our media and communication director has informed me that we have a record number of registrations. So obviously, a lot of people are interested in Morton's Neuroma. And tonight's webinar is also special because we have a truly multidisciplinary team. We have, as our speakers, an orthopedic surgeon, a radiologist, an interventional radiologist, and an anesthetist. So it would be really interesting to hear from all the angles. Before I kickstart the talks, a few housekeeping announcements. The first one is that the chat function is disabled, so please use the Q&A for your questions and answers. Second thing is it's important that we receive your feedback, and at the end of the discussion, there will be a QR code. Please take a picture of it. It will take you to the feedback, fill the feedback. There will be a code needed, which will be put in the chat. So use that code, and then you will receive the certificate. And once you have taken the picture of the QR code, you can, if you don't mind, you can leave so that we can have a feedback amongst ourselves as to how things went tonight. So I have the pleasure of inviting our first speaker, Matt Solan, very senior and respected foot and ankle surgeon, previous chair of the scientific committee of BOFAS and TPD for the KSS deanery. His special interest is gastrocnemius tightness and consequences, and he has done a lot of work on that. So Matt, I would like to welcome you to present your talk on the surgical aspects of the Morton's Neuroma. Thank you, Matt.
Thank you, Maneesh. Can't believe there's lots of people here when the weather's this good. Right, hopefully you can see the screen. Thank you, first of all, for inviting me. Why me? Well, basically, I was the last one standing. I was talking with Maneesh about this lecture series in general. We were talking about Morton's Neuroma, and I dropped the next speaker right in the deep end by saying, well, Andy, the radiologist I work with, knows a lot about this. He could give a talk for you. So having dropped Andy in, I thought I could sit back and relax and watch this evening. But then Anthony Sacalario was going to do the talk on the surgery, but he's gone on holiday. So Anthony, if you're listening from your holiday, it's a pleasure to sub in for you. And I guess there's a bit of poetic justice because no good deed goes unpunished. Now, those were Oscar Wilde's words. And I just want to do a bit more philosophy. Some of you may have read this book by a chap called Mo Gaudat, who was a bigwig at Google. He had a family tragedy and set off in search of happiness. And he decided that happiness, or perhaps we should consider this patient satisfaction, can be defined mathematically. So if the reality of your experience is better than you were expecting, then the right-hand side of the equation is greater than zero and you're happy. Turn that on its head, and if reality doesn't measure up to your expectations, then you are unhappy. So the moral of this story is we'd all be happier if we had lower expectations. And I say that as part of my introduction, because I just want you to lower your expectations about what the next 10 minutes involve. I can't possibly cover everything there is to know about Morton's Neuroma. So it's not a whole book chapter. Secondly, there's not a lot of science on this topic, something that people are working to improve, but I'm not going to be able to blind you with science. I can't tell you anything clever because after all, I'm just an orthopedic surgeon. And I don't really have a huge personal experience of the matter because Dr. Carne makes all my patients better now. So I think I probably excise fewer Morton's neuromas than any foot and ankle surgeon I know. If you do want to read the whole topic, then our chairman has published a very nice current concepts review recently, listed here. The aforementioned Sacalario and his team have written an EFORT Open review fairly recently, 2019. That's a good article. The red circles here, I found some typographical errors, and Mr. Sacalario is very keen on spelling, punctuation and the like. So I was delighted to find 4 errors in the abstract. So if you read the article and find any more mistakes, please send me an email. Science, is there much science? Well, this is 20 years ago now in the BJJ, and Rob Sharp and others from the fellowship program down with Terry Saxby in Brisbane published this paper. The size of the Morton's neuroma doesn't matter, and the educated finger and thumb are just as accurate as an ultrasound or an MRI. That was the message of this paper. Size doesn't matter. That made me laugh when you've got the 2 of the tallest orthopedic surgeons I know on the authors of that. Maneesh and his group again have done a randomized study into whether corticosteroid injections require ultrasound for guidance. It's a good level 1 study. And a group from Denmark a few years ago did a nice randomized study into whether it matters whether your surgical excision is from the top or the bottom, and it doesn't appear to matter. But most of the evidence that most of us have grown up with comes from last century. Roger Mann in 1980 and others who followed him with case series showing that most patients are happy most of the time if you take the Morton's neuroma out. And that's about as good as the science gets. So I could stop there and lead on to the next speaker, but I've got a few more minutes. So I thought we'd just spend a little bit of time exploring how to avoid redo surgery. So if a patient comes back with pain after a Morton's neuroma excision, whether you've done that yourself or it's come from a colleague elsewhere, it's not going to be a happy consultation. The question is why the pain is there. Was it a failed operation? There are reports of the nerve not being removed at all, or too short an excision, or perhaps there's a problem in the neighboring space. But more often than not, it's actually just the wrong diagnosis, and the metatarsalgia pain is coming from somewhere else. These slides are credited to Mark Davis, London, and this foot isn't going to benefit from having a Morton's neuroma excised. The pain is almost certainly coming from the second MTP joint, which is dislocated with this hammer toe. You need to think about the metatarsals in general. Here's a case with iatrogenic long metatarsals because 1 and 5 have been shortened. And as Maneesh alluded to, I'm keen on tight gastrocs. So if you placed a bet as to how many slides I'd get through before mentioning that, I think we're at the 5-minute mark. Sometimes it's the right diagnosis, but the wrong operation or the operation done wrongly. And this brings us to the debate about what to do if there's pathology in more than one web space. I'm not going to go into that now. Maneesh has published on this as well, but my advice would be to only use one incision and to perhaps consider excising from one space and just decompressing the other. It's important to take enough nerve out. When you resect the nerve, the proximal stump will always grow back. So a stump neuroma is not an accident or a piece of bad luck. It's a physiological response to the nerve injury. Every nerve stump will thicken up with a neuroma. And our job is to make sure that neuroma is no longer in the weight-bearing part of the foot. That means chasing it up through the interspace where it's out of harm's way. Sometimes you've got the right diagnosis, you've done the right operation, but maybe the wrong patient. So poor vascular supply, immunosuppressing drugs, or other causes for poor wound healing can be a problem. But it's also important to counsel the patient properly. Some don't like the relatively minor numbness that results after having the nerve excised, and it's important that we make sure we've set the levels of expectation appropriately. So it wouldn't be a surgical talk without some tips and photographs. On the left here, none of these are my photographs, but the surgeon here is displaying nicely the deep intermetatarsal ligament. It's deep. If you're a registrar or a fellow, you've got to go looking for it and then divide it carefully to allow, in the middle photograph, different case, but nicely illustrated, the nerve and bursa complex bulging up to meet you. The last photograph on the right is trying to show the nerve tracking proximally. So the toes are at the bottom of the picture, the ankles at the top of the picture, and you have to chase that nerve as far up as you can, stretch it and cut it proximally so that the stump retracts. A few other points on the photographs. There's a West retractor in each, and I know the surgeons who took these photos would want me to point out that they don't use those routinely. Normally it would be cat's paws and a surgical assistant to protect the skin and the soft tissues. So the West is just there for illustrative purposes. The other big bit of metal is the laminar spreader. I'd recommend a toothed laminar spreader. It slips out less easily, and I can't do this operation properly unless I've got a laminar spreader to push the metatarsals apart and facilitate the exposure. And the third point's a bit more subtle, but if you look carefully, in each photograph, the incision is quite distal, right down into the web space. And sometimes you see patients who've had an operation elsewhere, perhaps, and there's a very short scar and it's over the MTP joint level and doesn't extend distally enough to allow proper access. So that's a quick run through on how to avoid redo surgery. But of course, the most obvious way not to have to redo surgery is to avoid the operation in the first place. John Hunter, famous for his museum at the College of Surgeons, considered surgery to be an admission of failure. And of course, it is an admission that your non-operative treatments have failed. And our patients sometimes expect miracles, and they need to be reminded that even a small operation is really the nuclear option when there's plenty of other ways to try and help. So how are we going to make the diagnosis? We don't want to be calling it a Moron's neuroma. We only want to diagnose Morton's neuroma. And it's all in the history. Here we are, the features you can elicit from the history. Please note that none of these features are present in 100% of cases. So there's nothing that's pathognomonic of a Morton's neuroma. You've got to assimilate the data from asking these questions to help your judgment. It's important to look for features that aren't evident as well. And one of the things that always makes me pretty sure it's not a Morton's neuroma is if there's swelling. If there's swelling, it's much more likely to be joint pathology or possibly a stress reaction in the metatarsal bone. Examination skills. These are Mr. Sacalario's slender fingers and thumbs, and he likes to point out that if you twist your thumb sideways, you can press deeper into the web space. Get a better response when you're trying to palpate for pain. What about scans, MRI or ultrasound? Well, I would argue neither. 99% of patients presenting with metatarsalgia either have MTP joint overload with synovitis in the second toe knuckle joint or a Morton's neuroma. In my book, the first-line treatments for both these conditions are identical. So a scan, however clever it is to identify which pathology is the pain generator, serves no purpose until the first-line treatments have failed. So I won't get an ultrasound or an MRI, for that matter, at this stage and send them off for non-surgical treatment. Now, I don't want to be disrespectful to any allied health professionals who are listening, but a lot of the patients I see tell me they've done physiotherapy and have seen podiatry, but actually the evidence for how compliant they've been with those treatments is poor. And so I'm very happy to start another round of useful exercises, specifically stretching the tight calf, ensuring they understand the importance of wide-fitting shoes, and they don't have to wait 6 months for a podiatry appointment. If you point them in the right direction, they can get some pretty good insoles for a few quid from the internet. It's helpful to spend some time talking about activity modification and weight loss if appropriate, and the more the patient understands, the more likely they are to comply and benefit from your non-surgical treatments. If they fail, you might like to try an injection. Cortisones are standard, of course, and the routine is usually to send a patient to have an injection and book a follow-up for a random period of time later, let's say 6 to 8 weeks. Now, I have a bee in my bonnet about this because 6 to 8 weeks is nearly always exactly the wrong time to see the patient. Just long enough for them to forget whether it worked initially, but not long enough for the effects to have worn off. And some of you will have humored me by filling in a questionnaire that BOFAS sent around recently. looking at our practice after joint injections and therapeutic injections in the foot and ankle. And 82% of respondents always book a routine follow-up a short time after the intervention. And this I consider to be wasting everybody's time. So for many years, Dr. Carne, who's speaking next, and I have used a pain diary. I refer the patient, he does the injection, the patient records their scores. They don't have an appointment booked to come back to my clinic, but they are instructed to send back the diary when the effects wear off, and then I can follow them up appropriately. And we audited this, and only 9% of patients required an appointment within the first 3 months. But of course, sometimes the dog gets the homework, or they forget to do their homework till the last minute, and they make up the scores and send them back, which is disappointing. So Andrew and I have been involved in developing an electronic pain diary, which works quite well. It only takes a moment to register the patient. After their injection, they can log their scores, they get automatic reminders, and you get nice little graphs that show how they are responding to their injection. It means I can keep a track of my patients who are out there in the ether without fixed follow-ups and see how they're getting on. If and when it does wear off, I've then got the information to know whether the injection hit the right spot, the diagnostic information, and also some data about how long it lasted. They've then got different options. They could quit at that point and just live with the residual symptoms. We could consider a repeat injection or take a big step towards surgery. So if our basic treatments of insoles, stretches, and injections aren't sufficient, is there anything else to offer? And some of you will have read the papers recommending alcohol injections to try and deal with the nerve pain. That was popular for a while, 10 or 12 years ago, but didn't stand the test of time and study. And it's really the holy grail to try and find something less severe than a surgical solution. And that's why I expect most of you have registered here tonight, not to hear me talking, but to listen to Dr. Carne and his experience of radiofrequency treatment, and Igor with his work on cryotherapy. So before we move on to those speakers, just the take-home messages. Redo surgery is miserable for everybody, so try and avoid it. The best way to do that is to avoid surgery in the first place. And so don't list a patient for surgery unless you've got a concrete diagnosis, you've made good use of injection treatments and pain diaries to make sure you really know what's happening, and you've managed your patient's expectations. And that's how I like to look after these patients, and that's why I so rarely have to undertake a Morton's neurectomy. Thank you very much.
That was a super presentation, Matt, and you made me laugh when you talked about the grammatical errors of Anthony, because he's so pedantic about the grammar and everything else. And yeah, you made some very, very good pointers, which we will go through in the end. So next speaker is Dr. Carne. Andrew Carne worked alongside Matt, as you have heard, at the Royal Surrey Hospital in Guildford. He's a member of the British Society of Skeletal Radiology. He has a keen interest in ultrasound-guided procedures, and he's also Chief Clinical Information Officer for Royal Surrey and St. Peter's Hospital. And he's going to educate us today about his experience with radiofrequency ablation in Morton's neuroma. Over to you, Andy.
Thank you very much, and thank you for the invitation. As you say, my name is Andrew Carne. I am a musculoskeletal radiologist, and I am from Guildford and work alongside Matt and have done for a very long time. Let me just put this onto slideshow mode. Hopefully that's all full screen for you now. So I'm going to talk you through some stuff that Matt's already talked about. So what are the drivers for doing it differently? Well, all treatments may have complications with either ineffective relief of symptoms or worsening of the conditions. Complications of surgical procedure, I don't need to tell you about, you'll know all of these things. And once you have a surgical failure, you often require a more aggressive surgical intervention than you might otherwise. So what is the role of imaging? never do a test until unless you know what you're trying to get an answer out of it. So it's really to assist in the diagnosis where clinical findings are a bit unsure and you're not quite, and you're struggling to find out what's going on. So as we all know, it's not strictly a neuroma, it's a misnomer, it's a Morton's neuroma bursal complex, whether it's fluid around the nerve causing the pain or thickening of the nerve. But there's also a variety of other things we see, whether that's a complete plantar plate rupture or in a sort of attritional tear on the side, whether it's synovitis in the MTP joint, just a bit of OA, Freiberg, stress fractures. There's a whole load of things that can cause metatarsalgia type pain and can mimic a Morton's neuroma. So it isn't that, it's very reasonable to request imaging. So what sort of imaging? Well, ultrasound is actually pretty cheap, 40 quid. This slide's a couple of years old, but it's still 5 or 6 times the cost of an MRI scan. It's really easy to do. It's cheap, it's dynamic. You can talk to the patient as you're doing it. It means you can look at the other things at the same time and review the mimics, look at all the differential diagnosis you have, and you can tell patients about what's going on because you can give them the result while they're sitting there in front of you. You can then either proceed to treatment, or in the case of the way that Matt and I run things, we will often have a position where he knows that he's probably going to plan to radiofrequency ablation, and he'll put in his referral, he'll put query candidate for radiofrequency. And at that point, I can therefore do the scan, plan with the patient whether that's something they want to do my consent form there and then. And by that position, I'm not trying to consent for them when they're in the room waiting for a procedure, and I can go through the risk and benefits. So, as I say, cheap, easy, no ionization, radiation, very accurate, and same sensitive as an MRI. It is operator dependent, and therefore you may need some referrer buy-in from our point of view. I'm not going to get management, you're going to know way better than I do, but we just assess a physio scan and inject. And this is a video of what just a standard injection into a Morton's neuroma. So the white line coming in from the side is the needle tip, and you can see that's injecting, it fills the burst, so you can see the nerve coming across the middle, and we inject it straight into that. So it's pretty accurate in terms of, you always know exactly whether you've done the right thing. Over the years, we've developed a bit of a protocol for RFA. We've got a number of radiologists, radiographers, physios that we employ within the NHS that do scans. And so if we're going to commit to a radiofrequency ablation, I'm the one doing it. I quite like to have the opportunity to repeat the ultrasound, make sure I'm happy myself, make sure that I'm happy that there's conservative measures in place. There can be all sorts of things. Some of them are subtle. This is a small plantar plate tear. And if we don't get all those things, then we're going to get ourselves in trouble. So then I do the informed consent. And this is where we do it. I do it in the standard ultrasound room. This is not in a theatre environment. I wear a bit of a drape, but that's just so I don't get blood on my trousers. If it does get a bit messy, I always need an assistant, because you've got a drip stand with the fluid running in to cool the tip of the needle. I am going to put a bit more dressing on, so don't worry, it's not completely unclean. Do the scan, reassess, take some pictures on the screen. And then at this point, I'll put in the anaesthetic. From an anaesthetic point of view, I tend to use 10 mils of lidocaine around the tibial nerve. And then I used to do a superficial perineal nerve block as well, but actually I've adjusted that over time, and I now do an intermetatarsal block of the effective web space. So if it's a 3-4, I'll inject around the nerve proximal as I can be to do that. By doing the tibial nerve, you get the sole of the foot where your needle's going to go. And this is what the tibial nerve looks like. And you put your ultrasound needle in through the side, and you literally surround it by fluid, the black stuff, and that's how you do that. I'll show you a little video of what that looks like as you're filling it up. Actually, I won't. That's a still image for some reason. So positioning, different people do these in different ways. I'm always astounded because actually, in my view, the hockey stick pose is the easiest way to do. It's a one-handed technique, so it means that I can hold the probe with my thumb. That, because the probe is nice and small, it forces the metatarsals apart, which means I get a nice little field of view in the middle to do that. And the more you push, the more the toes come apart. And then you can either put your local anesthetic or your steroid or your radiofrequency ablation through the middle. We do standard prep, cleaning the foot up, betadine, a small incision once we've once the nerve block's kicked in, sort of 15 to 20 minutes later, and then spread it apart with some arterial forceps. And this is what the kit looks like. It's the same kit that you'll have seen. Some people use these for some of their shoulder work. So it's a Arthrotech radio frequency ablation device, and we set it on the ablation settings. The fluid attaches to a normal saline bag coming to the back, which is why you've got the fluid attached. Make your incision and ready to go. So we do it under direct guidance. So actually I scan at the time that I'm doing it. So the probe's attached to the generator, which I insert into the web space and then look on screen as I'm doing it. Control pulses of radio frequency then delivered, in which that causes thermal ablation of the nerve. So to show you what that looks like, this is the radio frequency needle coming in. And then the next slide is what happens when it goes through. So you can see that little shuddering in the background. I don't know if you saw that on the ultrasound screen, but that shudder is when you press the nerve, it gives this odd artifact. And then as you go through and make little holes in the nerve, this is the needle tip here, and that's the Morton's neuroma. That changes over time, and you get these little white tracks left behind from where you've been. So again, you could see that little odd artifact as the radio frequency probe, and then you get these white areas which build up over time, and they become more and more confluent as the nerve gets replaced by white areas that have been ablated. And then this is what it starts to look like near the end. So you've now got a really big area that's ablated. And that's my needle coming back through the end, getting bigger and bigger. Very boring if you're not a radiologist and you don't know what you're looking for, but hopefully interesting if there are any radiologists or sonographers. I'm going to stop there. So evidence. Where are we? There's a few small groups from a long time ago. Matt's presented some of the more up-to-date stuff. This is from 2012. So some of the information is a bit old here, but the position there was there's a statistical reduction in the pain scores after RFA. Pain scores were measured on a VAS, and another case here by Shooter, again, small numbers of patients, all use a very similar technique. This uses a slightly different needle to me, but it's a similar way of doing it. And they have a slightly larger numbers. They're up to 40 here. We are currently working on our numbers. We're now up to about 200 that we've done in Surrey and places nearby that have referred through to us. So we are now going to we have done an initial survey of the first 20 and then of the first 40, all who had quite good results, or not all. We had a 60% improvement rate, 2 with no difference, and 2 perhaps a little bit worse in the first 40. So we need to do a much bigger number because our mechanisms and how we do it have definitely matured a long time, having done them for such a long time. So in summary, RFA is a promising addition to the management of Morton's neuroma. If you've got a good algorithm and you can work out what you're doing, it's definitely giving us some short and long, medium term reduction in the number of patients presenting to open neurectomy. Initially, we thought it was about 70%. Matthew tells me that he does 1 or 2 a year. I spoke to Alex Denini last week, and I think he does done 4 last year. So we're doing very small numbers for a foot and ankle specialist centre. It's very quick outpatient. I had one particularly barking mad patient who cycled away from the procedure. So it is, I wouldn't recommend it. My first few patients, I put them on crutches and gave them a boot, and it was much more. But as time's gone on, I wouldn't advise people to drive afterwards, but pretty much you can walk straight out of the room just with a relatively simple dressing. So in summary, confirm the diagnosis, try more conservative measures first, informed consent, follow nice guidance, nice guidelines, do allow for RFA, but you need to audit what you're doing to make sure that you're following them. It's very low morbidity, reasonable results, but patient selection is key. And I think that's why we do this re-evaluation, so that we can make sure that we're assessing the patients correctly. We'll have questions at the end. I'll need to change that slide, but I hope you found that useful, and I look forward to the challenges later.
Thank you very much, Andy. That was really good. And yes, I'm sure there are lots of questions. I want to ask a few questions. But let's move on to our next speaker tonight. So Igor has come on Zoom all the way from Copenhagen, where the temperature is 30 degrees, I believe. So Igor is consultant anesthetist, and he's actually the CEO of Copenhagen Cryo Center and also the president of the International Society for Ultrasound Guided Cryoneurolysis. So I'm very interested to hear from him because in UK we don't have many people. I don't know of any orthopedic foot and ankle surgeon who does cryotherapy. So very much want to listen to this talk. Over to you, sir.
Thank you, Maneesh. Thank you very much for the invitation to participate in your webinar today. I'm an anesthesiologist and I work at, I have a private clinic called Copenhagen Cryo Center since 2014, and I work, I'm the only private or only pain clinic in Europe offering only one treatment. It's only cryoneurolysis. And then I am president of the International Society for Ultrasound Guided Cryoneurolysis, where we actually on 13th of May this year, we had the first conference in Copenhagen, and we had 65 participants from 11 countries. So I was invited to talk about cryo and the cryo for treating Morton's neuroma. As the previous speaker said that this is intradigital neuralgia, there is no unique definition of the Morton's neuroma. What is Morton's neuroma? Why it's happening? It's typically based on the clinical examination findings. We do in Denmark imaging studies. It's every patient is performing MRI scanning, and it's very confusing because in 80% of the scans we don't see. We just think that this is something which looks like Morton's neuroma, but we also find some other things like arthrosis or bursitis or free fluid around the joints. We know all the treatment modalities, rested activity, orthotic devices or shoe modifications, medications for pain relief, corticosteroids, surgery, cryoneurolysis, radiofrequency. I agree with the Matt that the surgery actually is the last option if it's necessary to do that. What is the basic mechanism of cryoneurolysis? You can see here on the picture, there is this is the cryo needle, and then you can see that the gas is floating on the outer side of the needle, and there is small narrowing in the end of the needle tip, which increase the velocity of the gas, and then it shows, it makes actually, it's known as, in physics, it's called the Joule-Thomson's effect, and then it gives the high velocity of the gas, which drops the temperature, and the outer surface of the needle that grows the ice ball. And then the gas is coming back through the inner needle, it's coming out directly to the device. After the procedure, it happens that the process called Wallerian degeneration, where we have the axon breakdown, and it's happening distally from the treated point. What is very important is that during the cryoneurolysis, endo, peri, and epineurium are intact. So it means that we actually, the nerve, we get a chance for the nerve to regrow without possibility of forming another neuroma. Axons regrows 1 to 2 millimeter per day. Duration is very variable. It's very depending old young patient position, where on the body is happening. It's variable sensory and motor block when we do the procedure. The first cryosurgical device was invented in 1961. And there was a little bit of problem with the device because it froze to 190 degrees. And there was some kind of, there are some articles where they describe the necrosis of the nerve because of the very low temperature. Because when you use cryoneurolysis, we have this secure window, which is -20, -88 degrees Celsius. What are advantages of cryoneurolysis? It's no formation of possibility of neuroma formation, can be used on large myelinated nerves, can be repeated because the nerve grows back, and office procedure. I do cryo 10 years now, and I have patients coming, some of my patients are coming actually regularly after 13, 14 months after the procedure, because the pain is back and they want to do a treatment again. So we do the treatment again, and they have a year again when they are pain-free. Contraindications for cryo, the first four are relative contraindications. The absolute contraindication for cryo is paroxysmal cold hemoglobinuria, but it's a very rare syndrome actually, because only 1% on the world population has this. So in Denmark, there's only 5 people with this syndrome. So we know them, and they have also some cards with their showing. The possible complications: there is no permanent nerve damage described as a result of the cryoneurolysis. It can come skin discoloration, thrombosis, infection, bleeding, like every time when we puncture the skin and do some kind of interventional procedure. In my clinic, for last 5 years, we have done 173 patients. And the observation of these patients and the questionnaires they are filling out is that 25% of the patients, they achieve pain relief from the day one. 75% of the patients have to wait about 25 weeks to achieve the full effect. I cannot explain why this is happening, because I spoke with several centers in England, the United States, and Belgium who performed this procedure, and they have the same perception actually. When I scan the patients with ultrasound 3-4 weeks after the procedure, I can see that the Morton's neuroma is gone. You can see only the nerve actually, but neuroma is gone. But why the patients have to wait 25 weeks, I cannot explain. The success rate in my clinic is 85%, and this result shows the potential of cryoneurolysis as an innovative treatment for Morton's neuroma. For a year ago, we started one PhD study with a doctor on working on the radiology department, and we will do 50 procedures. 25 patients will be in the group for corticosteroid. 25 patients we will do with cryo, and we have just started 3 months ago. We have treated 5 patients until now, so I don't have any results still. So, but it will be actually probably only a year and a half we will have the results. I have a short video where I can show you how we prepare the patient. This is not in my clinic. This is I was somewhere to do some masterclass. I don't know where. Now you can see that I do actually on the dorsal side. I'm not going on the plantar side, and I put the ultrasound in the here you can see. Yes, and I do local anesthesia, interdigital, in between the toes. I use only lidocaine. And now you can see the cryoprobe. Cryoprobe is we use only single-use probes. This one is 1.3 millimeter. And there's no need of making incision. You just puncture the skin because the needle is sharp. It's triangular one. The freezing cycles is 2 times 2 minutes just below the ligament, and then I pull the needle out and I do 2 times 2 minutes above the ligament. This is the cryo device. I can see the temperature inside the needle. I can see the gas flow. And when the procedure is over, so you can see here -78 degrees Celsius into the needle, the flow rate. and then how long we are freezing. Here you can see an in-plane. This is the needle you can see on the right side, and below the ligament you can see the ice ball, the black one. And because of the acoustic shadow, two-dimensional ultrasound, we can only see the top of the ice ball. And then the compression is coming out. This was the short video about the procedure. There is no lot of references about cryo and Morton's neuroma. I put some references which are actually very nice double-blinded studies about treating the knee pain after total knee arthroplasty. And the first article is preoperative treatment. The third one is also preoperative. And the middle is treatment of knee osteoarthritis, double-blinded controlled studies, which shows actually that the cryo has a very good effect of the postoperative pain. I have published some study about treating CRPS patients with foot neuropathies, phantom limb pain by cryoneurolysis on the amputated nerve. We are talking a lot now about using the percutaneous cryoneurolysis for treatment of acute pain. If we can treat the patients preoperatively and then reduce the opioid for use after the operation. And the results are actually very promising. Next year, we are coming with several publications where we can show yeah, that was my last slide. This was my these are my contact information. So we'll take the questions afterwards. Thank you.
Thank you very much. And yeah, we'll come to question answers in a little while. Matt, can I invite you? I think it would be useful to hear from you how to start a new procedure. So let's hear your take on something new if we are trying to do for our patients.
Thanks, Maneesh. Just give me a second to, I seem to have got the questions in the way. There we go. Just going to share my screen again. So I think some people are putting questions in the chat, which if you could put them in the, Maneesh, where they've got to go instead, in the Q&A section, then that would be better, because I think we can't answer them from chat. So I just wanted a moment before the discussion just to comment. Igor's presented some very exciting results with cryo. Andy's results with RF are good. And this may excite people to go away and look at different, less invasive options to surgery. In the UK, NICE govern what we can and cannot do. And the situation currently for radiofrequency is that you can start this. You have to jump through a few hoops and talk to your trust about introducing a new procedure, but that's not going to cause any problems really, because radiofrequency is used quite widely in different ways by the pain clinics and so on. You are encouraged to audit your results, as Andy said earlier. Unfortunately, for cryo, it is considered experimental by NICE, and you can't just buy yourself a cryo kit and crack on, because you would need ethics and R&D permission and everything that goes with that. So I don't wish to pour ice, haha, on Igor's work, but I think this would be difficult to start up in any of our hospitals here in the UK. So I just thought, Maneesh, it was worth pointing that out before we start the Q&A, because it may put a bit of spin on what people are asking.
Yeah, no.
Thank you very much.
That's lovely. No, I think it's very important to know about it. And you're right. You need to think about what you're going to do. So if I can invite all the speakers to turn on the video so that we can kick off the discussion. So first question is from Toge, and he has asked a very good question. Matt, it's to you. We have a history alcohol injections, as you said, and there was a follow-up paper after the first paper to say that patients had a lot of pain. And if you, in the first paper, it was 5% of patients who were not happy, were actually very unhappy, and surgery was very difficult in them. So what is your experience with radio frequency? If it's failed radio frequency, do you find that surgery becomes more difficult?
It's a good question. Am I unmuted? Yes, it looks like I'm unmuted. David Connell was a nice interventional radiologist who really took hold of the alcohol injection thing, and it's quite a number of years ago now. But as you said, the follow-up study showed that a lot of patients were having 4 or 5 rounds of injections, and still eventually it turned out the results weren't that great. So despite some initial encouraging results, I think it's fair to say that that procedure is discredited. And there were some reports at the time, if I remember, that the surgery was pretty messy afterwards because there was a lot of scar tissue and so on. I have had to go and perform neurectomy in a very small number of patients where Dr. Carne has zapped the nerve first. Some of the patients, it just doesn't work. Some of the patients, it stirs it all up and they're a bit sore for perhaps 2 or 3 days, sometimes a bit longer. So making sure they know what they're in for is important. And it sounds like that's a little bit different with the cryo. If they come to surgery afterwards, I would never know he'd been there. It is like a completely normal Morton's neuroma operation. So the perineural tissues are not scarred or fibrosed or anything at all. And I don't think I've had to excise a nerve that's been treated by cryo, but the small number where I've taken a nerve out later after radio frequency, I couldn't have told you that they'd had that treatment.
That's very useful to know. Thank you very much. The next question is from audience, from Ian Marshall. So it's to both you, Andy and Igor. Are there any reported post-treatment numbness with either cryo or radio frequency? Your individual experience, does it cause numbness afterwards?
Some of the patients can experience numbness on the inner part of the toe, but it's only for several days or 1 week maybe after cryo. I don't know after the radio frequency.
So radio frequency is not dissimilar to, I mean, it's less likely than surgery, but it's obviously more likely than the cryo option we've just been described. But that's with the full power radio frequency ablation. So there are other areas that use radio frequency ablation, and I don't do it in the foot because in the foot I feel it needs a full ablation. But if I'm doing a suprascapular nerve, sometimes actually I don't use the same power level. I use a lower power level and just turn the power down, and you don't completely destroy the nerve. So you just literally turn down the power and make it work less well. But in the foot, yes, there's definitely that happens.
Thank you. The next question is from my colleague radiologist Raj Bhatt, who is in Leicester. So Andy, he's asking you, how long does it take to do the RF procedure? And do you need to keep them in the department for observation? He's asked about nerve block, but you had answered that tibial block, you do tibial block and the interdigital. So if you can tell us about the time it takes and observation post-procedure.
So the time it takes, it's a sort of interesting one because I can, an afternoon in a PA bizarrely is 2 till 5, isn't it? Which isn't quite four hours, but I can do at least 3 in an afternoon, and that's partly because I overlap them. So patient number 1 will be in the room, and patient number 2, so once I do the nerve block on patient number 1, I stick them back outside. Then I can either do a patient number 2, or I can do a different procedure and then bring the next one in, because that will give me 15-20 minutes for that anesthetic to really kick in. But I do reserve an hour. It's generous, more than you need, but there's nothing worse than running out of time and overbooking a list. So I give myself an hour, but in the middle of that, I would generally either back to back another one, which will overlap, or I'll do a shoulder injection in the middle.
Thank you. Igor, how about you? Same question. How long does it take to?
Yes, the procedure takes about half an hour for Morton's neuroma. If I do suprascapular nerve, it's 15-20 minutes, but it's, you know, the radio frequency or cryo are the principle of the treatment is the same. We use heat or we use ice. The difference is that the ice ball on the with cryo, the ice ball is situated on the little tip, so I can control the size of the ice ball. I can control that I don't do damage on surrounding tissues. Compared to radio frequency, you cannot control the electricity, you cannot control the power. The warp effect, you cannot control it. So this may be the only difference.
I would like to ask you one question. You said that although 25% of patients start reporting improvement in pain from day one, but for 85% patients, it takes 6 months. So it means that about 60% of patients have pain till 6 months. Don't they become impatient? I mean, here, if I have done something and they are still in pain 1 month, 2 months later, they are not going to be happy.
Yes, but you know, I come back to the Matt's presentation. I do a lot of expectation. You know, what is the expectation from the patient? What are my expectations? Because we don't. I usually get patients referred from the orthopedic surgeons, and then I explain the patient the procedure, I explain everything, the outcome, and they say yes or no for procedure. That's why we don't have, you know, hundreds of thousands of patients. We have only 180 patients, and the problem now with the PhD study is that the lady doing PhD study, she cannot. The majority of the patients actually would like to go to the cryo group, and that's why a lot of them are failing out from this study, because we cannot take them to the corticosteroid group because the results are not so good. So. But why it's happening, I don't know. You have actually 2 clinics in London doing only Morton's neuroma and plantar fasciitis. And I spoke with the doctor doing the procedure there. He has the same problem.
Matt is, I think, typing an answer to this political question. I will actually, just for audience. So in as we know, in UK, I think it's only podiatrists doing cryo. Matt, do you want to say something about that?
Yes, I was just typing into the box because somebody flagged up a website. There are a couple of centers in this country doing cryo. I think one's in Sheffield, one's in London. They're the ones I know of. And the question I wanted to know whether they are not subject to NICE. I think probably NICE guidance is less strictly followed in some private medical situations. That's certainly true with some of the novel treatments that are used in orthopedics in the private clinical practice. But if you're trying to establish a new service within your trust, I think the governance leads, the first thing they'll do is go and look at NICE guidance. And I think therefore you would struggle to under current NICE guidance to set up without a research grant and all the governance that goes with that to set up a cryo service.
Yeah, I know that this is currently under review, under NICE review, the cryotherapy, but it has not been authorized as yet, but the review process is going on. Next is a surgical question to you, Matt. You gave very good pointers, really good, that go distal, because that's a common mistake. People don't go far distal. Second, MTP joint, clinical diagnosis, you know, a lot of patients, you just squeeze, palpate the joint and the pain is there. And that's one of the problems as well, because a lot of people just get an ultrasound done, especially in the community. They see the GP and it always shows a Morton's neuroma. And that becomes a difficult situation sometimes to explain to the patient. But the surgical question I was going to ask you was that do you anecdotally do you believe that when you're excising the neuroma, if you burn or cautery the nerve ends, does it improve the chances of success of surgery, or does it reduce the chance of recurrence?
I have no idea, Maneesh. I was taught to pull the nerve down as far as I could and then burn it with diathermy before cutting through the charred remains. I don't do that anymore. I don't think it makes any difference. as I tried to get across in the talk, I think you need to get as proximal as you can. A cut nerve will always form a stump neuroma. That's the pathophysiology. It's not an accident or an unlucky event. It happens every time. And as long as that's not in a weight-bearing part of the foot and it's up in the small intrinsic muscles, way up at mid-shaft of metatarsal or proximal third of the metatarsal level. So if you take out 4 to 5 centimeters of nerve, you've done a good job. If you've tried to use a small incision for cosmetic reasons and you've only resected 1 centimeter or 2, then you're much more likely to leave the stump neuroma in a bad place and have pain again.
Thank you. Next question is to both Matt and Andy, or mainly to Matt first and then Andy. How do you decide when you're going to use a steroid injection and when you're going to ask for radiofrequency?
So if you want me to answer first, I would, as I hope I got across, maximize the non-interventional treatments as far as I can. Stretches, shoes, insoles, counseling, etc. If that's not helping, then a cortisone injection for diagnostic and therapeutic confirmation. Don't forget, I'm not imaging them to start with. I send them for their insoles and physio without imaging, because it's not going to change anything I do to know precisely where the pain's coming from at that point. It's all just treatments for metatarsalgia. It's almost certainly the MTP joint or the nerve, unless there's something unusual clinically. So if they come back, then I want some diagnostic imaging information, and at the same time, the confirmation from the injection, the diagnostic information that the local anesthetic hits the right spot and makes a difference. That's why I'm a bit obsessive about the pain diaries and cortisone. I would never send somebody straight for radiofrequency without trying a cortisone injection at least once. And I would say more than half of our patients, and Andy, correct me if I'm wrong, but more than half will have had 2 cortisones before reaching for the more expensive and more interventional radiofrequency. Andy.
Yeah, so I'll add to that a little bit. If somebody sent me to one blindly and they'd never done any injections before, I would always still do at least one just to make sure it was on the money. The other thing is sometimes I will see plantar plate irregularities and I will be dubious whether it's the plantar plate irregularities or the neuroma that's causing the pain. We all know that incidental Morton's neuromas that are asymptomatic are really not very uncommon. You see them quite a lot. So if you scan contralateral feet of patients who have no pain at all in the other foot, you'll often see a Morton's neuroma, usually with less of a bursal component, but there is normally a bit of both. So, and if I see something wrong with the second plantar plate, I'll often inject the MTP joint from the dorsal surface just with a bit of local anaesthetic only, no steroid, and see whether that gets rid of their symptoms. If I can get rid of their symptoms just from a bit there, but equally, you've got to look back down the bottom and make sure it hasn't just leaked out of the joint and is surrounding the neuroma. So it is a bit more complex. But yes, the long and short of it is almost always do an injection first because you want to know whether it's going to work. And that's the only way you're going to judge it. And always do it as part of the procedure. And hopefully I've also answered the neuroma bursal complex question there as well.
Thank you. Igor, is that what you do as well? Do you inject steroid first and then try cryo?
No, I don't use steroids. I just inject local anesthesia, lidocaine, and then I do cryo.
So
immediately.
So that's the procedure. If
Yes.
patient comes with Morton's neuroma, you do it. Okay.
If I do other procedures, only plantar fasciitis and the Morton's neuroma, I do it like this. Other procedures, you have to do diagnostic block first, and then I use only 0.5 to 1 milliliter of lidocaine. It should be 50% pain reduction. So I offer the patient next time to come and then we'll perform cryo.
And just to be clear, Maneesh, I don't use steroid at the time of an RFA. Steroid is done as a sort of precursor. I know you wear that, but Igor's answer made that a little bit.
Perfect. Last question to both of you. How long the pain relief lasts after cryotherapy and after radiofrequency ablation in your experience? Forever?
I have patient from 1st of October 2014. She's still pain-free. My first patient, she was Morton's neuroma, and then she's still pain-free. But I have patients. I have patient actually with HIV, and there's a lot of things in his foot, but we find out also Morton's neuroma. I treated for 2 years ago, and now he's coming back next week to retreat it. So 2 years, but
So if there is a
if it
recurrence,
works, yeah, if it works.
if there is a recurrence, then you do cryo again.
Yeah, I'll do cryo again.
Okay. Andy?
So there are a few patients who you don't get the full response, and I know the American experience is to do 3. I think that's probably financially driven, and not really rule out until then. We do repeat on occasion. I think probably it's about 5% of patients will get a repeat treatment, but there are most patients. If it works, you know, the only time you'll see them is 4 years later when they come back and they think it's the left foot that you've done an RF, and actually it was the right, and they've got new symptoms on a different side. Which they're confused about.
Thank you so much, gentlemen. It's been a real pleasure, and I really appreciate your time, effort in making this webinar very educational and knowledgeable and interesting as well. Matt, your talk was really funny as well, humor, and really enjoyed listening to all 3 of you. We are now going to put the QR code on, and